Dear audience, dear jury, let me introduce my PhD thesis about current epidemiological and therapeutic landscape in Myasthenia Gravis, NMOSD, and anti-MOG disease. My name is Márk Pavlekovics, and I'm working as a neurologist in Jahn Ferenc Hospital. Here you can see my specific goals. Let's see in details. My first topic was a systematic review and meta-analysis entitled Plasma Exchange Might Provide Faster Relapse Control in Critically Worsening Myasthenia Gravis than Intravenous Immunoglobulin. Myasthenia Gravis is a lifelong autoimmune disorder. Approximately 1,500 patients suffer from this disease in Hungary. 15 to 20% of patients with Myasthenia Gravis experience at least one crisis in their lives with high mortality rate. It means that during the first crisis, this number is 3 to 5%, and it increased during the second crisis to 16 to 20. Here comes the question, how we can prevent the progression? The answer is with IVG or with Plex. But which one is superior? IVG is expensive, there is a shortage of supply, and the mode of action is unclear. On the other hand, plasma exchange requires special equipment, trained personnel, and it removes the applied therapy. There is no convincing evidence to support one over the other. So we set up a clinical question. What is the efficacy and safety profile of plasma exchange compared to intravenous immunoglobulin in Myasthenia Gravis treatment? Here you can see my PICO. I would like to highlight the outcomes. We measured the change in quantitative Myasthenia Gravis score, which is the score for measure the severity of the disease. The higher score indicates severe status. We hypothesized that Plex is superior to IVG in terms of efficacy and safety patient with moderate to severe Myasthenia Gravis. We have conducted our systematic search in 5 major databases with that search key. During the selection, we found eligible 3 articles, but for the statistical analysis, just 2 of them was good enough. Here you can see my forest plots. The first plot showed the efficacy measured on QMG scale in 2 weeks. The heterogeneity is substantial, and the mean differences was -2.8. All of the studies favors the plasma exchange, but these results, these findings are statistically insignificant but clinically relevant, because with plasma exchange we can eliminate one more symptoms of these. For example, respiratory failure or dropped head, dysarthria, dysphagia. My second forest plots show the number of adverse events detected in 30 days. The heterogeneity was moderate, and according to the odds ratio, which is 1.04, there is no difference between the 2 tools. As a summary, I would like to highlight the strengths that we involved just randomized trials only, and it was the first meta-analysis which evaluated only RCTs on this field. As a limitation, of course, there is a limited number of qualifying studies, and they use different treatment regimens. As a conclusion, we can say that plasma exchange might provide faster relapse control than IVG, and there is no significant differences in side effects, and further research needed on this topic. Our manuscript now under review in Q1 journal. My second topic is a registry analysis, mortality of aquaporin 4 positive NMOSD patients. NMOSD is newly discovered antibody-mediated demyelinating disorder of central nervous system. This condition requires treatment that differs from multiple sclerosis, and in Hungary the prevalence is almost double compared to the European average. Our aim was to analyze a mortality of aquaporin 4 positive NMOSD patient in Hungary and upload patient data and create an epidemiological landscape. Here you can see the actually analyzed population. During multicenter registration covering more than 20 centers, 168 seropositive patients were registered between 2006 and between 2017. We analyzed that patient population, and we were able to detect from this patient 146. Here you can see that the disease duration in the overall study population was 12 years, and the age at diagnosis in overall study population was 42 years. This corresponds to the other findings. From this population, 26 patients died during the 16-year period, and the distribution of mortality remains constant throughout the year, and the COVID-19 has not had an impact on it. The average age of death was 61 years, and the duration of illness only 6 years. Here we compared the disease population by symptoms onset. As you can see, in case of early onset, the disease duration was 9 years, and during the late onset, that number is just 4.5. It may indicate that the disease progressed faster in older age. Here is the comparison of living and deceased patient population. According to the data, we can get the conclusion that the diseased population was diagnosed at an older age, and the duration of the illness is shorter in disease. As a conclusion, I would like to highlight that maybe during the late onset NMOSD has a more aggressive disease course, and the average of NMOSD population still below the retirement age at death. The NMOSD register update is under process, like the population-based epidemiological study. Here is my third topic, the clinical evaluation of rituximab treatment experience in myasthenia gravis. It was a retrospective population analysis. Approximately 30% of myasthenia patients fail to respond adequately to standard first-line therapies. Conventional refractory treatment, including corticosteroid, azathioprine, cyclosporine, with these therapies, in 70% possible to reach remission in case of refractory. Rituximab is a treatment option for patients who fail to respond to the conventional therapy, and this is anti-CD20 B-cell depletion therapy. Since this is a new therapy, we have just limited experience and clinical data. We set up a question: is rituximab beneficial in every serotype of refractory myasthenia gravis? Is efficacy of rituximab effective at late and early onset myasthenia gravis? We analyzed 29 patients who met our inclusion criteria, and we conducted a retrospective analysis. From these figures, from these tables, I would like to highlight the time from diagnosis to rituximab was 7 years, and the duration of rituximab treatment was 37 months. In this figure, you can see that 79% of overall population reached improved status. And on the other figure, you can see that the overall decrease in steroid dosage was 86%. Here you can see the results of subgroup findings. From this, I would like to highlight that during the late onset, the improved status reached in 92%, while the early onset just in 73%. In the early onset group, 46% in a pharmacological remission, while other has other symptoms. In late onset, that number is 64%. As a conclusion, rituximab appears to be an effective treatment option for both serotypes. And I missed to write down, sorry, rituximab seems to be more effective in case of late onset patients, but prospective study needed in future with longer follow-up and with more patients. Now coming the statistical analysis part, here is the summary of my project. I was two-time lecturer of Neuroimmune Society Congress, and I will be a poster presenter on European Academy of Neurology annual meeting. Thank you for your attention, and let me finish my presentation with a quote. Research is to see what everybody else has seen and think what nobody else thought. Thank you for your attention.
Congratulations to your progress. With your second study, aquaporin 4, I'm coming from a very different angle, and aquaporin are regarded as water channels, and aquaporin 4 too.
Okay.
But then with aquaporin 4, there are lots of things which it may do. So what? I have actually two questions. That what aquaporin 4 does. The other one is that this kind of misbalance in sex distribution is extreme. So is there any kind of good reason what we can actually provide on this? Do we have any clue that why do we have this kind of big sex difference?
Thank you for your question. Regarding your first question, the aquaporin 4 is a channel on astrocytal-X, which is on the which is the brain barrier, and the antibody attacked that aquaporin 4 channel and destroy it, and after that the inflammation destroyed the whole brain system and cause myelitis and everything.
So this is rather a consequence than a cause.
Yeah. Yes, please. Thank you. The sex distribution. I don't know the exact answer, but if we analyze the autoimmune disorders, somehow these are female dominant, and this result can also see in the literature, so it corresponds to the other findings, but I don't know why the female population is more affected in this case.
Thank you. Amazing presentation. I have a question regarding your first topic. You said that the mortality after the second myasthenia crisis is much higher, so I would assume that the response to treatment is different. And I'm asking if that could distort your results, and could that cause this statistical heterogeneity, and if yet, could there be any measure that you can do to handle this?
Very good question. This is absolutely missed out from the RCTs. They didn't detect it while is it first or second or third crisis, and it absolutely causes heterogeneity, as you can see on the results. And somehow we can measure that, but this is unsolved problem for tomorrow.
Thank you.
For today, sorry.
Thank you for your presentation. My question is connected to your third topic, especially the treatment of myasthenia gravis. So when we use IVIG and plasma exchange, so my question is just in crisis, and when we use the rituximab, also in crisis or in which condition?
The plasma exchange is only used in case of pre-crisis or during the crisis, or maybe before thymectomy. IVIG can use as a maintenance therapy to maintaining the good status of the patient, and the rituximab is just like an interval therapy. So we want to reach a better condition. This is not fit to the crisis because it affects just later
I'm sorry, but I have to play the devil's advocate here.
Okay.
First, I would very reluctantly call this a meta-analysis. It's more a data visualization in my point of view, especially the second one with the number of adverse events, because you basically have, in the second paper, you have 1 adverse event and 3 adverse events. Were the adverse events defined the same way in the 2 papers?
Yes.
Okay. The other thing is that I would strongly discourage you from talking about heterogeneity in this. It makes no sense.
Okay.
So we are trying to estimate a standard deviation based on 2 data points, and that's not very sound. Nonetheless, I would say that it's very nice visualization, and you can absolutely publish it, and it raises questions. But I would definitely not call it, a meta-analysis just because you have something that looks like a meta-analysis. That's the main.
I absolutely understand, and we had a discussion with the statistician team, and we made the decision to handle this project as a meta-analysis, but we are aware the amount of data is not enough to make a mathematical analysis. So.
Okay. What I wanted to ask is this QMGS scale. How is it? What is that scale? Can you describe that, please?
Yeah. This is the scale to set up to measure the disease severity. It contains 30 items. All of the items are the most severe symptoms, and the symptoms are graded from 0 to 3. The 0 means there is no symptoms. The 3 means the severer symptoms, and yeah.
Okay. So it's a scoring system. It's a complex scoring system. Okay. The other thing I wanted to ask, that's your second project, is you mentioned that the disease is diagnosed with some kind of, what was the test that you used to identify the 168 patients?
We identified only the antibody positive patients.
Okay, so antibody positive.
Yeah.
Do you have any idea of the diagnostic accuracy of the serotests?
87%.
87%. Thank you.
Okay, so what happens in this case is when you're estimating epiparameters, there are techniques that can actually incorporate that you're missing a few patients. So it corrects for these errors. If you have an idea of what your error rate is, then you can correct for this error rate. You need to look into that.
Yeah, we have the statistical analysis part is waiting for the discussion, but this is a very important opinion, and we only analyzed the detected patient. We didn't count, or we didn't include it in the figures and tables.
Yeah, but then again, you are giving a prevalence estimate at the end, so for that at least it has to be incorporated.
I'll extend on that meta-analysis thing. You had 114 patients in 2 trials. Here I would really contact the people who conducted these trials for individual patient data analysis.
I tried to contact them, but I failed.
Okay, good. Then there is another way around. Are there any studies comparing either of 2 interventions with placebo?
Yes,
done properly, randomized control, double-blind, blah, blah, blah.
Yeah, there are some studies compared plasma exchange with placebo and intravenous immunoglobulin with placebo, and it, I think, meaningful to conduct how I'd say, sorry, I forgot the word, a network meta-analysis. Just we haven't got enough time for it, but.
So that would be one way around, and the other way around would be to get individual patient data from these trials and do the propensity score matching to compare these. Because I have a feeling that there are not so many trials performed, and the data set would be manageable. So, but I can see that you are in the desperate need of good data, and there are none.
Yeah.
And then that brings me to another thinking, you mentioned that you have 1,500 Myasthenia Gravis patients in Hungary. How many centers do handle them?
Around 20.
Around 20. Okay. How many?
But most of the patients, sorry, are in our hospital.
Okay, most are here.
Yeah.
How
yeah.
many? 1,000?
No, more. 7,500 according to our knowledge. 800, yeah.
800.
Our knowledge.
Okay. How often does the disease worsen? And I'm sorry, I don't know that.
How often?
Yeah.
It depends on the serotypes and the patient condition, but yeah, thank you.
Okay, but okay, if you have 800 patients and currently you have only 114 patients in randomized controlled trials comparing that, isn't that a good field to do this trial?
Absolutely, yes, yes.
Because you would be the largest trial in the world. And I hope other centers are your friends, then you would have a nationwide study. Nobody in the world has done it. So that would be my way of thinking, and you would be the most famous guy in the world. Yes,
thank you.
Obviously. And then maybe another question. You mentioned that these two therapies are used in worsening or pre-worsening only. Would it make sense to have some intermittent therapy, like small boluses, boosters, to maintain the patients without worsening? Because we do that in heart failure, for instance, with some drugs. Would that make sense?
I think no, because we have other tools, other drugs for this. We use immunomodulatory treatment for the patients, and I think, but I don't know the exact data, but I think azathioprine and cyclosporine is more effective in that field than
What about
plasma exchange.
rituximab you have mentioned?
Yeah.
What about rituximab? Would this also be potentially useful to maintain the patients?
How I see, this is a very effective drug to silence the symptoms, but it required a lot of paper to give to the patients, so we can't use rituximab as a first-line therapy at acetylcholine receptor positive patient population, because there is this is not, how to say, there is no guideline for it for now, because this is a new drug, but we started to use rituximab in MASC positive patients as a first-line therapy, and it is very, very effective.
Actually, you might be the one who modified the guidelines.
Yeah, maybe.
Thank you. And you are not only a researcher, but you're a clinician, so I would be interested in this 1 compared to 3 adverse events in the meta-analysis. What were these? Because one adverse event or one side effect can be clinically very much important. So what were these? Were these important from the clinical perspective?
From the clinical aspects, it says I have to highlight that these findings are biased, because the detection of adverse event was not equal in the RCTs. But if it's gonna be true, it's a good news to us, because if plasma exchange is effective, we can use it, and because it is it requires a machine, and this is a very invasive. It can be invasive. If it didn't cause a lot of side effect, and if it's effective, this is a good news, because we can use a effectiver